Hello, my name is Mia Colette Malone, and today I'll be sharing COVID-19 associated quarantine on negative psychological distress in long-term care patients with dementia. So less than 1% of America's population lives in long-term care facilities, but as of February 4th, 2021, this tiny fraction of the country accounts for 36% of US COVID-19 deaths. So some COVID-19 statistics. There have been over 1,276,000 total cases, over 161,000 total deaths, and over 32,000 total number of facilities affected. So to regionalize this data, in Tennessee alone, there have been 10,202 reported deaths. And of these, the reported deaths in long-term care facilities has been 2,427, which accounts for 24% of the deaths in Tennessee. So COVID-19 transmission statistics in long-term care facilities suggest that there needs to be an increase in social isolation among elderly individuals. However, there is a concurrent dilemma. My hypothesis is that if long-term care patients with neurodegenerative diseases such as dementia are placed in COVID-19 associated quarantine, then there will be an increase in psychological distress and a decrease in patient outcomes. So to define some key terms, long-term care facilities is a broad term that includes all types of facilities that provide housing and care to seniors and others. Psychological distress can be defined as a state of emotional suffering associated with stressors and demands that are difficult to cope with in daily life. More specifically, it is a construct that is defined by the common variance between anxiety, sadness, fear, anger, guilt and shame, irritability, and other unpleasant emotions. Neurodegenerative diseases are a heterogeneous group of disorders that are characterized by the progressive degeneration of the structure and function of the central nervous system or the peripheral nervous system. Common neurodegenerative diseases include Alzheimer's disease and Parkinson's. So, social restrictions in long-term care facilities. Right now, there is a reduced social component and protective response against COVID-19 in long-term care facilities. And the most significant impact of decreased socialization has been the limited visitation of loved ones, the decreased interaction with volunteers, and minimized physical and social activity in these facilities. This social isolation is categorized by psychological and physical symptoms that worsen patient outcomes. So social inclusion operates as a psychosocial buffer for increased well-being in response to stressors. When an individual has the perception of social inclusion, they're more likely to have an increase in self-esteem, sense of worth, personal distinctiveness, and rate of success. Overall, an improvement in psychological, physical, and mental health outcomes. So when there is isolation from a socially conducive environment, there's a loss of that psychosocial buffer in response to a stressor, which diminishes socially supportive systems as a coping mechanism. Isolation from socially conducive environments also predicts a negative psychological distress during the COVID-19 pandemic. So the psychological effects of social isolation can include acute stress disorder, irritability, insomnia, emotional distress and mood disorders, depressive symptoms, fear and panic, anxiety, and stress. Psychological effects also suggest that there might be an increased rate of suicidal ideation that accompanies elevated levels of depression and anxiety. The physical effects of social isolation can include an increased risk of premature mortality across all causational factors, which exhibits a statistical comparison to deaths caused by smoking, obesity, and physical inactivity. Physical effects can also include an increased risk of stroke, heart disease, and neurodegenerative diseases such as dementia. So patient outcomes. Social isolation exhibits a 50% increased risk for the development of dementia. In individuals previously diagnosed with dementia, negative psychological distress is a contributing factor to increased cognitive decline and a decreased outcome in patients. So future directions of this research. It needs to be assessed across dimensions of differing mental health disorders to determine the diverging factors between the associated symptomology. This research also needs to be expanded to determine differences between various ethnic and socioeconomic backgrounds under the same conditions. So in discussion of the information and statistics presented, there's some important takeaway questions that need to be considered. So the first is, how can we include social components for these individuals without increasing their risk of exposure? Social components are crucial, as found by the findings of this study. But right now, because of the physical limitation to our socially inclusive components, we've lost a sense of social community, which has decreased psychological buffers to stress. So it's important to consider how we can include more social components in long term care facilities. Another takeaway question is, do you think online communication is enough to compensate for social isolation? So, our method that we have used since the beginning of the pandemic has been reaching out to people through Zoom, FaceTime, text, and even social media. But it's important to consider what crucial components of social connection are missing from an online communication platform. And the final question to take away is, what sociological factors have prevented us from hearing about the mental health of the elderly, specifically long term care patients during the pandemic? Because of the amount of effect in long term care facilities for COVID-19, we would think that we would be hearing more of a perspective from this subset of the population, but that doesn't seem to be the case. So it's important to consider what is contributing to our lack of information concerning their narratives. Thank you so much, and I hope you have a great day.